Obamacare was two pieces of legislation. And the first piece was signed into law on March 23rd, 2010. And when the second piece came into play, the two pieces together gave birth to what we commonly refer to now as the ACA. ACA stands for Affordable Care Act. So the two pieces of law together gave us the thing called the Affordable Care Act, which is what we're struggling to implement, now. Here is, on the left side, what the goals of the act are, and on the right side are some of the key strategies to make the act work. The triple aim, former CMS Administrator Don Berwick, after the ACA passed, he created this focus called the triple aim. The purpose, here are our goals. This is what we want to see at the end of the day with Obamacare. We want to see better care for individuals, we want to improve population health status, and we want to lower per capita costs. So every strategy is geared towards one of those goals. The first one, going to the right side, is to expand coverage. I mentioned we got about 34 million Americans out of 47 million who have no insurance, right? We want to expand coverage to them, right? 17 million Americans that don't have insurance are on what we call the individual market, meaning that they're out there trying to get insurance and pay for it themselves. They're not getting it through an employer or what have you. And this was a huge problem because of some policies that were in place by insurance companies that kept them from getting insurance. Group coverage, you could be sick as a dog, or you could be walking dead. But if you have a job with a group policy, you have to be covered. If you're the walking dead and you don't have a job and you want to go out and buy insurance, insurance is not going to give it to you. They're not going to give it to you. They're not going to give it to you. We have 17 million of those people. So wanted to expand coverage. I'll skip to the third bullet and then come back to the second bullet. So candidate and then later President Obama and the Democrats in Congress said, what we want to do is we want every American to have a responsibility for getting insurance. So they put an individual mandate in place. That individual mandate kicks in, next year, 2014 is when individual mandate kicks in. And what you're going to have to do, if you don't have, what each of us is going to have to do is when we file our income tax for 2014, the forms will have been revised to have a place where you have to demonstrate that you have insurance, prove that you have insurance coverage. If you can't do that, and by the way, and then there are things that they do to help you get insurance. I'm just giving you the requirement. If you can't prove that you have insurance, then you're going to be hit with a penalty. The penalty is going to be $95 assessed if and only if you have a tax return. So if you have no tax return, you have no penalty. Your tax return, you have $95. So it's $95. So they want you to go out and buy health insurance, and that number goes up. That amount goes up in subsequent years. And you'll see it laid out in that thing.
Regardless of income. That's a flat fee.
Yeah, everybody has to prove that they have insurance or pay the $95. If you have no income, you're not going to be, you're not going to, there's no return. So you're not, so it wouldn't apply to you.
My understanding was that it was $95 or 1% to 1.5% of your income.
Maximum, maximum $95.
I know that there's an effort from young people rejecting this new law, and do you think there might be an allowance for this group who feels that if they don't want insurance because they're young and they're not ill and they're not going to be ill,
this is why, you're getting to exactly where I was going with this. And I want to back up to the second bullet, and then I'll tell you why. The second bullet explains why the third bullet exists. The insurance industry said when the government, what government did, what the legislation did was say, okay, insurance companies, you got to clean up your act. We don't want you denying coverage because of pre-existing conditions. We don't want you, this is my Denzel Washington story. We don't want the Denzel Washington deal. Remember the movie?
Sure.
Yeah. Now, what was the issue in that movie?
Her daughter didn't get the surgery.
His son could not get a heart transplant. But it wasn't because he was insured, wasn't insured. What was it? You remember? No.
Didn't have the money.
But he had insurance. He had insurance. Denzel and his wife was sitting at the table when the hospital administrator called him in, thinking, this is a piece of cake. My son's going to get taken care of. He's got insurance. The hospital administrator, go.
The insurance company denied the heart transplant.
No.
Was it pre-existing?
No.
He couldn't pay his part.
Why don't we watch the movie?
You don't remember? Okay, here's what the deal was. He had insurance, but there was a lifetime cap on the amount of benefits and expenditures. And what the hospital administrator, played by Anne Hetch, said was, the transplant cost, the post-transplant, immunosuppressive drug is going to exceed what your insurance covered policy coverage. So take your son home and figure something and prepare for him to die. She didn't say it that way. But, that was. My industry, I was working for the hospitals. My industry was outraged at this movie. They were outraged at this movie. Anyway, I kept telling them, relax, it's just entertainment. But what happened, you remember what happened? So, of course, what he did was he took over the hospital. And that's why we were upset. Not a guy. But the point was lifetime caps was an issue. So the federal government says no more lifetime caps. No more exclusions for pre-existing conditions, no more lifetime caps, no more denying coverage after you have approved the patient, and then as soon as the patient started using it, you go back in his or her history and you find something that they didn't quite put right on their application, and that's called a rescission. And then, so you resize them and disallow them after the fact. No more of that. And we want you to allow kids up through the age of 26 to stay on their parents' policies and not necessarily be college. If you were a college student, you could have done that. But now, I shouldn't tell you that. You still need to go to college. You could always stay on when you were a college student, but they took away the college school requirement. So here's the link between bullet 2 and 3. The insurance industry said, yeah, this gets back to your point. The insurance industry said, okay, we'll play. But we need healthy people buying insurance. If you make us do this, the only people that are going to be signing up are who? People who need care. And you know how that's adverse selection. You know how insurance works. So you've got to put in a requirement that everybody, the young surfer dude, my invincible jock son, who thinks nothing will ever happen to him, you gotta make them buy insurance. So that's why the individual mandate became so important, to balance the needs of reforming the underwriting things that we didn't like, and to balance the scorecard. But then the Democrats chickened out. They made the penalty for not doing it so low that it's a no-brainer. In California, for an individual, now the exchange, we'll talk about the exchange later, the new rates that have come out belie a little bit of what I'm saying. But at this particular point in time, the average cost for an individual for a policy, individual policy, was $451 a month. $451 a month versus $95 a year. A year. What do you got to figure out if you're my son? I can give you the $95. Go away. You know? So that was a cop-out. Now, this is my editorial comment on this. I think what the Democrats in Congress did, because I used to work for I worked for the California State Senate for 10 years at one point in my life, and we did our research when we do things. We do our research. You test stuff out. I think they tested what the tolerance level was going to be for attacks like this. And Democrats are politicians too. And so they want to make certain they don't put themselves in a box where they tick off the electorate. So I think they did some nullification. There was another inside the Beltway strategy here too. And I'll share this with you. And this is opinion. I don't know this to be fact. But there were many legislators, Congress, the Democrats wanted to have what we call a public option plan. They wanted the government to have a plan that it provided, a Medicare-like plan for the uninsured. Well, to compete, they felt that the only way you can help keep healthcare costs or premiums down with commercial plans was if the government had a commercial plan that competed with them. Because if the government's plan was going to be arbitrarily lower in cost than what the private market was doing. So if you got the government plan competing with the private market for commercial or private pay patients, it's going to force the private insurance companies to keep the cost. So this public option was in the law, or not in the law, in the bill that was going through the House of Representatives. It was all set to go through the United States Senate, or the Senate version was going to include the public option as well. And that was going to be kind of the end of insurance. The public option was going to go through there as well. Then unfortunately, and sadly, Senator Kennedy died. And the vote was very, you didn't have a vote to spare because the Republicans were not going to do this. So he died, and I forgot the guy's name, he only lasted a minute. A Republican was elected in his place. So that cut the vote margin down in the Senate to get this thing passed. The only vote that was hanging out there to make the 60th vote, and you needed 60 votes to not have a filibuster, to make it filibuster proof, was Senator Joe Lieberman. And Lieberman said, I don't like the public option. You take it out or you don't get my vote. And that's the story behind the story, which why we didn't have the public option to compete, with the other plans. So back to the point. So the thinking was, well, if we make this program, if we put it together in such a way where people are not motivated to go out and get insurance, because I'd rather pay the penalty, than the cost, then it will fail. And the only result would be to bring in a government plan. So we lost the battle in Congress to get a public option, but arguably a strategy was put into place to bring that option back in future years when this didn't work. Hence, the need or the desire to keep the penalty very low. Did I get that? You follow what I'm saying here? Again, that's inside the Beltway type stuff. Yeah.
Would you be able to tell me if this projection is correct, that in California there would be 3 million who wouldn't be insured, 2 of which would be undocumented immigrants, and 1 of which would just be people who decide it's not worth it?
Your number is very good. We have about 7 million uninsured people in California. The mandate and the coverage, the extended coverage, let's talk about who it excludes. It excludes undocumented immigrants. It excludes Native Americans. It excludes people who have certain specific religious beliefs. It excludes legal residents who have been in the country for less than 5 years. and there's one other two categories I can't recall. So that takes that 7 million uninsured Californians who are eligible for this, it takes that number down to 4 million. Okay? Yeah.
Why Native Americans?
Sovereignty. Sovereignty. So the Native Americans run a sovereign nation within a sovereign nation. Oh, by the way, the Native Americans can get it, they're just simply not mandated.
And they would be able to get it under covered cap?
Yeah, sure. Yeah. In fact, wait a minute, even the undocumented would be able to get it if they're willing to pay for it.
But they wouldn't qualify for
They wouldn't qualify for the subsidies. Okay, so that's the way that works. So that's what happened with that. So that's the story behind the underwriting reforms and individual mandate and how they are tied, how they are tied together. Employer mandate, we're going to talk a little bit about that in a moment, but yes, the employers were made to play. And there were some specific rules about what employers needed to do. But here is, I'm going to jump ahead a little bit. Here is the piece that doesn't follow. As you all have known, you probably reported on it as well, is President Obama, by administrative action, delayed the employer mandate 1 year, from 2014 to 2015, because the employers rebelled and said it was too complicated, we don't know how this is going to work, yada, 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 so they put it off. I'm going to say this piece now, and this is me editorializing, so this is my opinion, this is not necessarily fact. When you look at the provisions, and we will later, when you look at the provisions of Obamacare with regard to the employer mandate, it exempts from the penalties all employers that have fewer than 50 workers. Doesn't even apply to them. In California, that's 96% of all the businesses. 96% of all the businesses in California, it doesn't even apply to. So what the hell are we talking about? Why do they need an exemption? Why do they need to put it off for a year? That's my opinion, editorial comment. And I'll give you let me give you the answer to that question. Next year is what? Next year is when it goes into effect, but what is next year also? Election. It's the mid-year elections. And the Democrats are afraid about what generally happens in mid-year elections. And they don't want to give fodder to a campaign to lose seats. And the employer mandate would have been one of the things that, so I'm sure the Democrats pled with President Obama and said, get this out of the way until after the election. And that's what happened. Anyway, that's
There is talk about including deferred action students in the options for Medi-Cal and Covered California. Do you know anything about that and what the likelihood is of that happening?
I know about it. I can't tell you what I don't know about the likelihood of that happening. I don't. But I tell you what I'll do before next week. I'll check it out and see what I can find out for you on that. Can you make a note and remind?
We can't hear the questions back here. So if you could just, that's okay, if you could just repeat the
Go ahead.
I was just asking if there is talk about including undocumented students who qualify for deferred action both in California for the Medi-Cal option and the Covered California, and how likely it was it would happen.
And I don't have the answer to that question. But I will next week. Okay. Okay. So that's the employer mandate, and that's the history behind all that. So the goals, and this is what's going to change the delivery model. Other strategies: improve the outcomes, quality, and patient safety. And this is mainly focused at hospitals with encouragement or some shared focus with insurance companies. We'll talk about the different types of structures of redesign next time we're together. But basically, what we're doing is putting together some solid metrics that hospitals and doctors and others are going to have to demonstrate that improvement in care is occurring. Let me give you one example. We won't go into a whole lot of it, but one example. 1 out of every 5 patients who is admitted to a hospital is readmitted to the hospital within 30 days after having been discharged. 1 out of every 5 patients who is admitted to a hospital is readmitted within 30 days after being discharged. The goal is to reduce, if not eliminate, hospital readmissions. And there are some specific strategies, including some payment strategies in the law that will hurt hospitals who don't meet the goal of reducing those readmissions. That's just simply one example. There's a lot of other things. We'll talk when we get to cost containment. We'll talk about some of those other things there. But
Is there any main reason why there is this remission?
well, there are a number, not a main reason, a number of, well, I guess there is. The main reason is the lack of coordination of follow-up or post-acute care. Patient leaves the hospital sends them home with discharge, medications and discharge instructions, but nobody follows up, that doesn't happen. And then the patient gets sick and have to come back to the hospital. So what the government is saying is hospitals, you're going to, and they have a lot of strategies to make this work, you're going to be responsible for the post-acute care as well. And some of the insurance companies are jumping ahead on this, jumping way ahead on this and figuring out ways to do it. Anthem Blue Cross perhaps is one of the most progressive companies when it comes to dealing with this issue. I'll give you 2 examples. They hired, one example is they bought a company called CareMore. And CareMore is expert at dealing with patients who have severe chronic illnesses. The CareMore model is when you go to a hospital and you're a complicated patient, there's a judgment that's being made right up front. And that judgment is the physician who was responsible for taking care of that patient failed. Because the thought is, once you get to the hospital, that means everything else that was being done didn't work. So what CareMore does when the patient gets to the hospital is, how your doctor admits you to the hospital and he or she treats you when you get into the hospital? CareMore says, oh, the hospital that has an agreement with CareMore says, no, you get the hell out of the way. You failed. I'm being dramatic. They do it a lot nicer than that. They don't say, get the hell out of the way. They say, get the heck out of the way. You failed. They put their chronic disease management expert on that patient's care while he or she's in the hospital. And then when the patient is discharged, they don't go back to that doctor who failed. The doctor who failed doesn't get a second chance. They're put into a special program for chronic disease management. And that's the way they keep these patients from getting sicker and getting their chronic diseases managed better and keep the readmissions down. Blue Cross bought them. They bought this company because that's only one of the strategies that Blue Cross has put into place. They want better care management of these people who, remember what I said? For every 1% in chronic disease, 6% consumption in healthcare. That's what they're fighting. And this is a strategy to help do that. The other thing they do is kind of like, well, it's not quite the same, but the airline industry, this is my airline industry analogy. The airline industry has only really one rule. A pilot friend of mine told me this. When you go to pilot school, there's only really one rule. And that is the number of landings should equal the number of takeoffs. So that's the only rule. Any landing is a good landing. But that's the only rule. So everything you do is to that. So they have checklists. Pilots have checklists. It's one of the strategies. that they have to go through and everything. Even though they've been flying forever, and they have checklists. We are finally beginning to adopt those checklists. But here's the story I want to tell that kind of is an offshoot of that. IBM had a computer, or has a computer, that they call Watson. Somebody may have heard of Watson. Watson can process, I'm thinking, if I remember correctly, it's either 60 million or 90 million. It's one of the two, I can't remember which. It's either 60 million, it can process 60 or 90 million pages of data per second. Okay? It's the world's most super of all supercomputers. It's the Jeopardy champion, for example. I mean, it learned how to play Jeopardy. It learned how to play Jeopardy. It beat the two best Jeopardy champions in the United States. It also is the best chess player in the world. Watson now is in medical school. Watson now is in 2 medical schools, learning how to be a doctor. Get where I'm going with this? Okay. We're moving more towards evidence-based medicine. Watson is going to be able to put in all, give me all your data. Remember, I can do 90 million pages a second. So it really don't take, give me everything you know about the patient, and I'm going to tell you what the right thing is to do.
That's scary.
That is very scary.
Blue Cross owns Watson, and it's their intent. Watson is a dramatic story, but it's their intent to start using or applying evidence-based medicine. And Obamacare encourages that, and I'll talk more about that when we talk about cost containment next week. I'll talk more about this evidence-based medicine approach, you know, that this is all about. Eliminate fraud and abuse. You know, when you talk about an industry that is close to $4 billion a year, you're going to have fraud and abuse. That's a lot. That's 4 trillion. I'm sorry, I said billion. 4 trillion, almost $4 trillion in healthcare. You know, you're going to have bad actors, and so they want to do that. And then after this last comment, we'll take a break. Bend the cost curve. Remember, I said earlier that healthcare cost on average was increasing about 6.77% a year. Obamacare wants to bend that curve, wants to take that 6.7 and reduce it by 1.5 points. Take it down to 5.2 or whatever, 4.2 or whatever the difference between 6.7 and 1.5 is. That's the goal. So there's some strategies in which that occurs. But here's the point. At the end of the day, the law, and then we'll take a break, the law calls for $917 billion in cuts to the cost of health care over the next 10 years. Okay, so that's the goal, to find a way of carving out or reducing it by $917 billion, you know, and bending that cost curve by 1.5%.